It is my honor and privilege to introduce to you Dr. Monique Hinchcliff. She is the Director of Clinical and Translational Research for Rheumatology, Allergy, and Immunology at the Yale School of Medicine, and she's the Director of the Yale Scleroderma Program. She received her medical degree from the Rosalind Franklin University Chicago Medical School and completed her medicine residency at Norwalk Hospital in Connecticut. She completed rheumatology fellowship training at Northwestern University Feinberg School of Medicine in Chicago, Illinois, while earning a Master of Science degree in clinical investigation. Her research program includes clinical, interventional, and observational studies with the goal of better understanding systemic sclerosis and identifying new and repurposed treatments for patients with systemic sclerosis. Help me in welcoming her to our group.
Thank you so much. It's a pleasure to be here. I'm going to share my screen. So now I have to figure out which screen you're actually seeing. Are you seeing the Candy-Bactin slide? Can you see my slides here?
Yes.
Okay. All right. So I'm just going to do play from start. See if this works. Can you see my slides?
New treatments for patients.
But the whole, okay, so I guess it's over here. So weird. Okay, so I'm gonna have to change my gaze. So again, I'm Monique Hinchcliff. I was at Northwestern for, I got 14 years after I trained, and then I was recruited out to the East Coast to head up the Scleroderma program out here. So thank you for the nice welcome. And I put new in quotations because these things aren't all new, but these treatments aren't all new, but they may be new to you. Some of them were new to me. They'd been around for a while, but patients or other physicians had alerted me to their, to their being around. And so I wanted to bring those to you, the information to you. So I have a few disclosures. I do some medical consulting for some pharmacy companies, one of which is Boehringer Ingelheim, and I am discussing one of the drugs that they market. I do some medical consultation and they are funding me to do research, but I don't have stock in the company or anything like that. I received funding from Cadman, which is another pharmaceutical company. And again, when we're discussing treatment, I'm certainly not meaning to be giving medical advice to you for your own personal care. This is really just information that you could take back to your physicians that are local. So there are some goals of the presentation. I'd like to explore newer treatments for Raynaud Phenomenon with you. Spend a little time discussing nintedanib and tocilizumab, which some of you may be taking for your lung disease from scleroderma, and then share with you some information that I've learned in the last several years about maybe some additional treatments for GAVE and GERD and SIBO. And then again, some new information about sodium thiosulfate, which is not a new treatment, but the way that we're using it now to treat our patients. I'll admit this person because now I'm the co-host. Sodium thiosulfate's not a new treatment, but we're using it, we're injecting it intralesionally into calcinosis cutis lesions. And we've had some promising results with that treatment. So let's see, how do I advance here? Here we go. Sorry, bear with me. Okay, so I just include this slide just to make sure that we're all on the same page. There's three types of systemic sclerosis, or also called scleroderma. The limited cutaneous type, which probably the vast majority of patients have, And then there's a rare type called systemic sclerosis sine scleroderma, which means you may have a lot of the internal organ manifestations of the disease, but you don't have any skin involvement. And that's a tough diagnosis to make because the patient is missing the cardinal feature that we look for as physicians, which is the tight skin. And then there's the diffuse cutaneous systemic sclerosis type, which is about 23% of our patients where the skin may be tight all over the body. How do we detect these different types? We pinch the skin with this archaic system, which that's the focus of a lot of my research, is to identify better ways of assessing treatment response in skin disease for you using gene expression or artificial intelligence analysis so that we can move away from this pinching you test. It was an advance. It was developed in the 1990s and is now the #1 outcome for skin studies in scleroderma, which I believe is the reason why we haven't identified any effective treatments for skin disease, is because our outcome is insensitive and inaccurate. So I include this slide. This is from a medical journal, so it's not geared towards patients, but I wanted just to stress a few things. As you can see, so this is the mortality rate, and you can see that as of 2000, it's been steadily going down. Can you see my pointer? Yes, okay. So this is really exciting, I think. I entered the field right around this time, and just to see this downward trend from deaths occurring that are attributed to scleroderma or contributed by scleroderma. I think this is really promising. And you can see all the treatments here. So back in the 1960s, we had D-penicillamine. In the late 1970s, ACE inhibitors were invented, and some of you may be taking those for hypertension, for high blood pressure. So those drugs are captopril, benazepril, things like that. The drugs end in pril. And then there's some like azathioprine and methotrexate that were developed, and these were discovered mostly in lupus and rheumatoid arthritis, but applied to patients with systemic sclerosis. So, well, I won't belabor this point. In the late 2000s, mycophenolate mofetil was starting to be used for systemic sclerosis. Autologous stem cell transplant. Northwestern was a big site where that was ongoing. And so that was developed, and then rituximab. And then super exciting is the FDA approval for nintedanib and tocilizumab that came in 2019 and 2021. We hadn't had any FDA approved treatments for scleroderma until 2019. So Boehringer Ingelheim was the developer of nintedanib, and we were really excited when they did this huge multinational trial of patients and showed an effect, albeit modest, in treating lung disease. And so this is a really exciting time in systemic sclerosis. I am getting at least 1 or 2 requests per week from drug companies inviting me to enroll patients in different clinical trials. And that is just, it's so exciting to be able to be part of the discovery of new treatments. So we'll first talk about SSC-Raynaud phenomena. Maurice Raynaud was a physician in France in, I think, the 1800s, and he wrote his thesis on this condition where patients noted their fingers changing color. And so it was named after him, Maurice Raynaud, but I just a little tidbit there. So I include this slide because I want you to see that systemic sclerosis is a disease that affects the small vessels. So you can see this is, the nail would be up here. And again, you can see my pointer. Shake, yes. Okay, so the nail is up here, and these are the tiny vessels that if you had a magnifying glass and you were looking at the area right below your cuticles, you would see these tiny hairpin shaped vessels. this is what a patient, this is what a healthy individual, this is what their nailfold capillaries look like. These are patients with systemic sclerosis, and you can see as the disease advances, these vessels can become more and more abnormal. We use this to detect the difference between primary Raynaud phenomena, which millions of people have, which is not a big deal and doesn't need to be treated, versus secondary, which is seen in patients with another autoimmune disease like systemic sclerosis or lupus. And this is a way that we've been increasingly using nailfold capillaroscopy to diagnose patients with earlier systemic sclerosis, hopefully before the onset of any internal organ damage. And so we can institute preventive treatments and other treatments to prevent disease progression. So just keep this in mind, because this is going to come to play a little bit later. So I included this. Yesterday was an extremely busy day. It was the deadline for submitting your research posters for the upcoming American College of Rheumatology 2022 meeting, which is going to be held in Philadelphia this year. And so I have a resident, Abhishek Madhathanapalli. He's at the University of Connecticut, and he and I did a study where we experimented with using this Dynolite, which is a handheld device. And we just pull it out during clinic and we hook it up to a laptop, and we can take these really cool pictures of the nailfold capillaries. And so the pictures that I showed you in the last slide, albeit very beautiful, require a very expensive camera. It's called Nailfold Video Capillaroscopy, and it's super expensive, and it takes time. Whereas the Dynolite is this handheld instrument that we can just whip out in clinic and take these images. And so he is going to come back and do another research block with me, where we look at the change over time in these vessels and see if treatment can prevent some of these abnormalities from occurring. So it's not meant for you to read this slide, but just to know that we are doing active research. The first treatment for Raynaud phenomena, and when I was in Chicago, I would seriously say to people, you need to get out of Chicago. You need to go during the winter months. If you have the means to winter elsewhere, that's probably the best treatment. It's very hard for patients in cold climates to, as you all know, I'm preaching to the choir, to prevent Raynaud attacks. No matter what treatment we give, if you are exposed to cold, it's tough not to have an attack. For those of you who cannot relocate to a warmer climate during the winter months, Cabela, and I, again, don't own any stock in Cabela, but they make a really great rechargeable heated glove that stays hot for a long time and has different settings. So, low, medium, and high, so you don't get burns. But the patients have really found those helpful. We tell patients to have mittens and gloves at all times of the year, because air conditioning in the summer can be quite problematic as well. And then it's not just keeping your fingers and toes warm, it's really keeping your core warm. And so sweaters, camisoles, long underwear, however to keep your core warm is important as well. And please interrupt me if you have, you can unmute yourself and ask a question, please. This is something that a patient told me about, Okupa. And you can buy it on Amazon. It recharges it. It's the size of a mouse, of a computer mouse. So it's kind of discreet. And you can just pull it out of your purse and turn it on, and it keeps your hands warm. I think it stays warm for 4 to 6 hours, depending upon how hot you have it. But patients have really enjoyed that. And we have patient advice forms that we give out at the end of visits. We can share them electronically and give patients hard copies. And so whenever a patient comes in and tells me something that they have found handy, I add it to the form to share the information with others. These have been around for a long time, but not everybody knows about them. It's activated charcoal. So you take them out of the packet, you shake them, and they stay warm for several hours. And I've seen them at Costco. You can buy big boxes of them, and they stay hot for several hours. This is something, again, that a patient last year or 2 years ago told me about. So she was a patient who was wintering in the desert out in California and still was having terrible outbreaks of Raynaud Phenomenon, sending me pictures, and she was on maximum medical therapy. I was giving her, everything I could think of to really no avail. And she found this cream online. It contains magnesium and arginine, which are both vasodilators. And it's produced by a family company. And you can find it on Google and click and order some. It hasn't been tested in a clinical trial, obviously. So there's no firm data in the medical literature that it helps, but a patient, again, whom I saw and couldn't help, found that this was quite helpful for her. So I thought I would share the information with you. This is an intervention that we've been working really hard to develop at Yale. We are able to admit patients, but they have to be admitted to the medical intensive care unit at our institution to get this intravenous epoprostenol. So epoprostenol is a prostacyclin, and I teach, when I'm teaching the residents and fellows, I think of the blood vessels cycling through the small vessels. So that's a way to remember its mechanism of action, but it's a very potent vasodilator, and it really works. In Europe, they're able to get this to patients in the outpatient setting. So my colleagues in Europe will tell me that they'll admit patients to their facility for 3 to 5 days, just a few hours of an infusion each day. And they do this monthly, and it works great. But in America, to my knowledge, few companies are able to do that, or few hospitals are able to do this because of medical legal issues. And so we have to admit patients to the medical intensive care unit, which obviously in the last few years with COVID, there were no beds. And so it really underscored the need to be able to do this in the outpatient setting. So this was a patient of mine who in late June of 2020, we admitted him for IV epoprostenol, but the decision was made not to give it for reasons that I won't bore you with. This was his finger by August. So just a few months later, he came back to clinic, and this is what his finger looked like. And this was in spite of, maximum outpatient therapy with all sorts of medicines. Every medicine that we could think to give him, we were giving him, and his finger still progressed to become gangrenous. And so we admitted him, insisted that he get IV epoprostenol at this admission. And we also started him on opioids. So the medicines that we've all been hearing terrible, terrible things about, deservedly so, because of all the addiction issues. But this is really a time when opioids are indicated. And I had to talk to this patient for many, many times to convince him to take opioids because he was so scared of becoming addicted to them. But for this indication, pain is a vasoconstrictor. So pain makes your vessels clamp down, and that's appropriate because back in the day when we would get shot or, mauled by a wild animal, we didn't want to bleed to death. And so our bodies, when we're in pain, the vessels clamp down to prevent us from bleeding to death. That's appropriate. But in this case, if we're trying to re-instill blood flow to a finger like this, we can't have the patient be in pain, or else our therapies are doing less than maximum benefit. So convinced him to take opioids, which were helpful. And then I saw him again in May of 2021. And when I go to speak to the hospital, the hospital powers that be, I show this slide and to underscore the need that we really need to get this treatment more widely available. Isn't that incredible? So he didn't lose his finger. The surgeons recommended, lopping this tip of the finger off. And I said, stay the course, stay the course. It should come back. And this is what we see. If we treat severe Raynaud effectively, that we can prevent loss of a finger. And he really didn't lose much tissue at all. And the finger's fine. No pain. He's off opioids. It was a success story. So this is a slide meant for the fellows, so it has lots of detail on it that's not important, but I just wanted to include it because this is the little pump that infuses the drug. It only has a 6-minute half-life, so the drug, in 6 minutes, half of the drug is degraded, but yet it's been shown to improve Raynaud Phenomenon severity, and this has been published in the medical literature. And so we think it's because of its other properties, like its effect on platelets, which are the cell, they're parts of cells, but they are responsible for clotting our blood. We think that it has effects on the lining of the blood vessels, so those are called endothelial cells. And so we think it has effects on those cells to help them remodel themselves. And then it's, again, a potent vasodilator. So it increases the blood flow to the digits. And again, in Europe, EUSTAR is the European Scleroderma Trials and Research Group. And they've published that it helps digital ulcer healing. And like I said, they have patients come to their clinics from daily for 3 to 5 days for a few hours, get their infusion, and they do this monthly, and they can prevent these critical cases from arising. So if you have any pull at your local hospital, you should contact them, the powers that be, and ask them to try to develop a protocol to be able to do this, because I think it would really help patients. So now we'll talk about SSC lung disease, systemic sclerosis lung disease. And again, these are not necessarily new treatments, but newish. So we recommend, when I see patients with lung disease, you have to be elevating the head of your bed. We do not want you to be breathing in your stomach contents or the contents of your esophagus overnight. And so this is critical. We want to prevent injury. And I'll show you a picture of a Scleroderma esophagus on a later slide, and that'll prove to you why none of you should be sleeping flat. So mycophenolate mofetil the brand names are Cellcept and Myfortic, and that's kind of the cornerstone of treatment. The trials that were conducted with Boehringer Ingelheim, patients were on background therapy, and the most common background therapy was mycophenolate mofetil. So this treatment is kind of the mainstay of lung disease treatment in patients. Cyclophosphamide has been around a long time, rituximab, but the two I really want to highlight are nintedanib, which is, again, FDA approved for lung fibrosis, and then tocilizumab, which gained FDA approval in 2021 for lung inflammation. And so we'll talk a little bit more about that. And again, there's many, many clinical trials that are ongoing. So it's an exciting time, and I encourage you all to participate in clinical trials if you're so inclined, because that's the way we make discoveries. So this is how it works. So these blue cells down here are fibroblasts, and fibroblasts are all over the body. They're the cells that help us heal if we get a wound or we have any injury. They come to the area where there's an injury, and they lay down proteins that close a wound or repair a hole in a blood vessel internally. And so they're critical. Without them, we couldn't be alive. But in scleroderma, they can become overactive, and almost like a cancer cell, they spew out fibrotic proteins. So like collagen, for instance. And so that's what the drug companies were focused on turning off. So this is a schematic. Up here, you see the cell membrane of one of these cells, and there's these receptors here on the surface of the cell. And this is the nintedanib molecule. So all these blue molecules circulating around, they get into the cell, and they prevent these fibroblasts from becoming too activated. And so this is a lung. This is supposed to be a lung sac. And you can see, so this is where your air would be if you were breathing in and breathing out, the alveolar space. And so the nintedanib can get into the alveolar space and inhibit the overactivation of these myofibroblasts. So that's its mechanism of action. This is what tocilizumab does, or Actemra. So this is a schematic from COVID, because COVID was effectively treated with tocilizumab and led to me not being able to give tocilizumab to any of my patients with scleroderma lung disease, because it was all being taken up by COVID patients. So that's why hopefully everybody's getting vaccinated and boosted, so that we'll have Actemra available for you who need it. And there's no vaccine for scleroderma as far as I know. So this is a schematic of the COVID virus, and you can see that it gains access to the lung and recruits all of these inflammatory cells that create lots of inflammation in the body. And so tocilizumab binds to the IL-6 receptor and blocks it. And so IL-6 can't bind and create all of this inflammation. So tocilizumab acts in a totally different way. It's involved with inflammation. It blocks inflammation, whereas nintedanib is more of an antifibrotic. So some of you may be on both of them. And hopefully the reason is clear, is that they're for different indications. So what am I talking about? Inflammation and fibrosis. So this is a CT scan of a lung. So this is, if I took a machete and I cut you in half and looked at your lungs, this is what we'd see. So this is your spine, and so this is your back, and this is the front of you, and these are your lungs. And so they should all be black, like the background. And you can see that there's these areas of haziness, and this is called ground glass opacification. Apparently someone thought that this looked like ground glass. I don't think I've ever seen ground glass, but suffice it to say that that's what it's called. And this is evidence of inflammation in the lung. And so when we see this on a lung CT, the pulmonologist will often recommend that this is an appropriate indication when we see this for giving a patient tocilizumab. Whereas if on this side, you can see the, all this, it's called honeycombing. Can you see that? Oops. Can you see that that kind of looks like a honeycomb? There's all these areas of air, and you can see that the air sacs are larger, and that's because fibrosis has occurred that's pulling them apart. There's on both sides of the lung, and then this is called traction bronchiectasis, where you see these are the bronchioles, so these are the airways, and they're pulled open by fibrosis. So here you can't see those big airways as much as here, and that's because there's a lot of fibrosis in this patient's lungs. So this would be a patient who would be appropriate for nintedanib. And then these yellow arrows are pointing to a dilated esophagus. And so this is why you shouldn't see this. Your esophagus should just look like it should look closed. But you can see on these images that the esophagus is open like a circle, and there's an air fluid level. So this is actually fluid inside the patient's esophagus that's making it look like this. And that is a setup for aspirating your stomach contents when you sleep at night, or if you're doing anything where you're laying on your back or your stomach flat, you're setting yourself up to be breathing in tiny, tiny amounts of this stomach acid. But you can imagine the lungs do not like anything from the stomach to be inside them. And that will create inflammation. And long-term, that will create fibrosis. So please, please, please elevate the head of your beds. Now we'll move to SSC gastrointestinal disease. GAVE is one of the manifestations of systemic sclerosis or scleroderma. And what does GAVE stand for? It stands for gastric antral vascular ectasias. Watermelon stomach is an easier way to remember it. And you can see this is the inside of the patient's stomach, and you can see the stripes of the these are vessels that are close to the surface of the stomach lining, and they're prone to bleeding. And so this is a really common cause of severe anemia in patients with systemic sclerosis. So what do we do about this when we see them on an endoscopy? Our GI colleagues, here's the vessels on a different patient, and they take, they do an endoscopy, and they take this radio frequency ablation probe, and they can put it down through the endoscope. And then you can see in panel C, it's at the end of the endoscope, and they basically just coagulate. I mean, think of it as like frying. They're basically frying the vessels with energy so that they don't bleed anymore. So they're coagulating them so they stop bleeding. And you can see here the patient having this done with the purple probe here. And this is what it looks immediately after treatment. So looks kind of scary. There's all this white inflammation and some blood, but this is following therapy several weeks later at a repeat endoscopy, and you can see the stomach looks beautiful. There's none of those vessels are present. And so radiofrequency ablation is kind of the standard of care for this. And it often takes multiple treatments. I had a patient in Chicago, I think, who had to have this done every other month for like 30 treatments. She had terrible gave. But eventually they had gotten rid of all those vessels that were close to the surface, and she has not had gave since. So it does work. So now we'll talk about SSC gastrointestinal disease, GERD, which stands for gastroesophageal reflux disease, as I'm sure many of you know. I include this image just to underscore what can happen in the scleroderma esophagus. So this is high resolution esophageal manometry. And again, this is done during, this is done by our GI colleagues, but this is a healthy person. So the red indicates muscle contraction, and you can see that this is the patient swallowing up here. And then going down the esophagus, the wave of the swallow is advanced, and then you go down through the lower esophageal sphincter, which is at the bottom of our esophagi. And so our food goes into our stomach, and that's how swallowing should work. In patients with systemic sclerosis, your throat, the muscles in your throat are intact. So the swallow is normal, but the smooth muscle inside the esophagus isn't functioning properly. And so you're basically left to swallow. This is a very severe case. So this is not what is happening in all of your esophagi, but this is a severe case where all the smooth muscle has been atrophied and it's not working properly. And so this poor patient is left to swallow by gravity alone. So only gravity is pulling the food and liquid down into the stomach. Again, this is what an esophagus can look like in a scleroderma patient, dilated, and again underscores the need to make sure that the head of the bed is elevated. And reflux, this is just to tell you that reflux occurs after you eat. And so the medical term for that is the postprandial period. That's when most reflux occurs. So that's why we want you to eat as early as you can. So that's why the clock is here to signify, try to eat dinner at around 5 or 6 and not be eating at 9 or 10 right before you go to bed. If you have a very large stomach that's pressing on your esophagus, if you're overweight, that can make GERD worse. So, the recommendation is to try to exercise and get to your ideal body weight, to elevate the head of your bed, as I mentioned. And there's a couple ways to do this, by just simply placing a block underneath the head of your bed, or by purchasing one of these wedge pillows. Patients don't really, from what I've gathered, do not find these very comfortable. I certainly wouldn't want to sleep on something that looked like that. So I think just putting a couple blocks underneath the head of your bed is probably the easiest way to make sure that your head remains elevated. Here's the pharmacologic treatment. So there's antacids. These are sold over the counter, obviously. H2 blockers. Zantac was taken off of the market a few years back, but Pepcid and Tagamet are still around. And then most of you are probably taking a proton pump inhibitor, and this reduces the amount of acid in the stomach. There's Zegerid. There's all sorts of ones. You can find them all over the place. They sell them at Costco quite cheaply. But many of you are probably taking these. But then there's this newer, and I don't know how long this has been around, but it was new to me since I've come out to the East Coast, my GI colleague introduced me to it. And so I've been recommending it to all of my patients, some of whom have found a lot of benefit from Gaviscon Advance. You want to get the type that says Advance on it. So there is data for Gaviscon Advance. It is an alginate, so algae from the sea, and it comes in a pill form, capsules, and liquid. And if you're failing other therapies, or if you want to try to get off some of these therapies, if you're a doctor and you decide that this is best for you, you can try these alginates. And basically when the algae hits the stomach acid, it forms a gelatinous raft. So like Knox blocks on top of your stomach acid, on top of your stomach food. And so it would be up here. This is where the alginate would be, excuse me. And so it's a physical barrier to reflux. And then when your stomach acid and your stomach contents leave your stomach and move into your small intestine, out goes the Gaviscon Advance. The alginate is not absorbed into your bloodstream, so it doesn't have side effects. You take it with each meal, pop a capsule or a teaspoon of Gaviscon Advance, and it prevents reflux during the postprandial period. So again, that's right after a meal until your stomach empties. And so it has worked very well for some patients. They've come back and told me that it was life-changing. So we're giving this advice to all of our patients who come to see us at Yale, that they should give it a try. It works. This is a different study that was done and published in 2017, where they looked at patients with systemic sclerosis who had partial response with the treatments that we typically use for GERD. And they randomized them to either having this domperidone, which is a drug that's not even available in America. It was taken off the market because it had some serious side effects. But patients, we still do use it in some patients. It's a good pro-motility agent, so it helps the stomach and the intestines empty. So we do prescribe it in the United States to some patients, and we just monitor their heart, the EKG very carefully while they're taking it. But I thought this was an interesting paper because they randomized patients to domperidone, which is kind of this dirty drug with lots of potential side effects, to an alginate, and it was placebo controlled, so patients didn't know what they were getting and the physicians didn't know what patients were getting. And they looked after treatment at 4-week assessment, and they performed all these different outcomes, and they found that there was no difference in any of these outcomes in the patients with refractory GERD between add-on domperidone versus add-on alginate. And so if it were up to me, if I could take an algae that doesn't get absorbed and doesn't have side effects versus domperidone, which can cause all these nasty side effects, I would opt for the alginate, and I'm sure most of you would as well. So proof that it is helpful. The last thing I'm going to talk about in terms of the gastrointestinal tract is SIBO, which is small intestinal bacterial overgrowth. And this is common in patients with systemic sclerosis. And as the name implies, it's just too much bacteria in the small intestine. And so these are the protective factors that occur naturally in our body. We've got our gastric acid, which helps kill extra bacteria. We have our secretions from our gallbladder and our pancreas that help us digest things in a speedy manner. We have the motility of our intestines that keep food moving constantly, and so on and so forth. Commensal flora are the bacteria that are common and are present in all of our intestines, and commensals are our friendly bacteria. And so these help us break down the food that we eat. So these are the systems that the body has naturally to prevent too much bacteria from growing in our intestines. Unfortunately, in patients with systemic sclerosis, some of the motility is affected. So food isn't going through the intestines as quickly as possible. And so that increases the risk for too much bacteria to grow Again, a lot of you may be on acid neutralizers, the proton pump inhibitors, so you may have less gastric acid, and that may contribute. That's very controversial. It's not it's been studied widely, but never proven. But there is that theoretical concern that when we give you proton pump inhibition, we may be setting patients up for having a higher risk for developing too much bacteria growing in the intestines. So this is why there's a search for better treatments for this. So the symptoms are many. I'll just let you look through those for a moment. But I've been fooled. I've missed this diagnosis in a few patients. And so I always try to keep this diagnosis in the top of my head when I see patients who may just be complaining of, fatigue or some upset stomach, nausea, and I may not be thinking of SIBO in those patients. I may be thinking it's, the medications I'm giving them are giving them nausea, or, I'm thinking anemia, is a cause of fatigue, or they're hypothyroid. I'm thinking of all these different diagnoses and I forget about SIBO. So if you have any of these symptoms, you might want to talk to your doctor about being checked for this. So this is how we treat it. We give antibiotics. It makes sense. There's too much bacteria growing in the small intestines. We give antibiotics. Sometimes we give 1 or 2, or some patients get triple therapy, and we kill off all these evil bacteria and the patients are made better. Only sometimes they're not. And these have side effects, right? So we want to use these judiciously. Also, the best one is rifaximin, and rifaximin is super expensive because it is not absorbed into the bloodstream. It stays in the intestines and kills off the bacteria that are overgrown, and so it doesn't get absorbed, and it doesn't have the side effects that many of these other antibiotics have. But it's expensive, and it's often not covered by insurance. I mean, more often than not, I would say. I prescribe it, and the patient comes back and says, my insurance won't cover it. So what do we do? So this is something that a patient told me about. They took matters into their own hands and did some investigation, or perhaps they saw their naturopath. But I thought this was really intriguing when I read this paper. So this Dr. Shadid is at Pittsburgh, which is a huge scleroderma center. They see tons of patients. They do lung transplants for patients. So a very reputable place. And this Victor Shadid, he conducted a clinical trial where he randomized patients to rifaximin, which is the wonderful antibiotic, versus Candibactin AR and Candibactin BR. And these are, the AR stands for aromatic oils. So this is a mixture of thyme and oregano, sage leaf, and lemon balm. And the BR stands for berberine, and that's an alkaloid. It's found in barks and leaves and twigs and rhizomes and roots and the stems of various plants. And these two, so patients were given them twice a day, and versus getting rifaximin, and there was no difference. So this was the title of the publication: Herbal therapy is equivalent to rifaximin for the treatment of small intestinal bacterial overgrowth. So super exciting. This, I'll caution, by saying that this was in a small number of patients. It hasn't been validated in an additional study group. So we always in medicine like to see multiple groups publish the same findings before we really accept something as fact. But I think it's at least worthwhile to think about using this natural treatment to treat small intestinal bacterial overgrowth. So talk to your doctors about it. It's expensive though, and insurance won't cover it. You have to buy it online and you have to pay for it yourself. So calcinosis cutis, hopefully most of you do not have to grapple with this. It's basically calcium deposits in the skin and soft tissue in patients. This is a patient of mine, again, a very severe case. Thank God most of us don't have to to deal with these issues. But so the most common presentation of calcinosis cutis are these small little lesions in the hands. The hands is the most common place to have this. And so for something like this, the treatment would be very different than for a patient who has extensive severe calcinosis cutis. And I'll put in a mention that this is thought to be due to that small vessel disease that I showed you with the Nailfold Capillaroscopy, because patients with diabetes and patients with peripheral arterial disease also get calcinosis cutis. So it seems to be due to small vessel injury. So diabetics get a lot of small vessel injury because there's just too much sugar in their blood, and it's very harmful for the small vessels. And then peripheral vascular disease, as the name implies, is disease of the small vasculature. And they get calcinosis cutis too. So we think that this occurs in patients with systemic sclerosis due to the small vascular disease. Again, more research is needed. There's tons of treatments that have been proposed for calcinosis cutis, and there's more. This is just a few of them. We've chosen to try sodium thiosulfate. We've tried it IV. It's very difficult to tolerate. It causes nausea, and hasn't worked very well in our hands, at least. You can give it, not PO. You can give it as a cream. PO is by mouth. So as far as I know, there's no sodium thiosulfate pills. So I'll fix that. I'll fix the slide. But you can give it intralesionally. So you can rub it on your skin, or you can inject it into your skin. And that's what we've been doing a lot at Yale. And I'll show you some of our success stories. So lots of different drugs. There's never been a clinical trial that has shown, there's never been a clinical trial, and there's never been a clinical trial, obviously, that's been effective. Why aren't we doing clinical trials in calcinosis cutis? Primarily because we don't have a good outcome to measure change. And so that's another area of research that is active in our community. So this is sodium thiosulfate, where we injected it. So this is a patient of mine, and she was getting monthly injections into her skin by the dermatologist. And it's painful. She said it was painful. But this is in October of 2021, and this is in June of 2022. So you can see I tried to indicate, because the orientation of the picture is a bit different. So the blue, you can see the blue circle before, and this is the same area in June, and then the green and the red circle. And then the purple, I think, is really most profound. She had these open kind of ulcers of her arm, and those all healed. But it took monthly treatments. The treatments are painful. So clearly we need to do better. So the summary, I left lots of time for questions, and we can end a discussion. Really, I'm interested to hear what you have all found to be helpful for your different symptoms. But for Raynaud phenomena, patients have shared with me, the Okupa rechargeable hand warmer, the hot hands activated charcoal, the Nutrisol cream, and then this IV epoprostenol for Raynaud phenomena that we are really working hard at Yale to be able to administer in the outpatient setting. For lung disease, we have nintedanib for mostly fibrosis, and tocilizumab if you have lots of inflammation in your lung. Again, you need to elevate the head of your bed to prevent the reflux from occurring. We have radiofrequency ablation for gastric antral vascular ectasia or watermelon stomach. We have alginates for refractory GERD that seem to work just as well as domperidone, which is a kind of a dirty drug. And then the Candibactin AR and BR for the small intestinal bacterial overgrowth. And I forgot to include the sodium thiosulfate intralesional treatments for calcinosis cutis. But again, yesterday was a big deadline. And so I was putting these slides together kind of in an exhausted state of affair. Of course, speak to your doctors, your naturopaths, your nurse practitioners, your advanced practice RNs, whomever you're seeing. This is certainly not meant to be medical advice to any one of you in particular, but I just wanted to bring forth some of the things that I've learned in the last several years, mostly from patients who have done their own research and found things and brought them to my attention. We have our team. One of the things I really like to do is introduce young people. So all of these people want to go to medical school, except for Cass. She wants to be a researcher. These are 2 high school students. So we started a program in New Haven to attract high school students to come and work with us and do research with us. So these are our first 2 candidates that were nominated by their science teachers locally because of their interest in science and aptitude in science. And so they're working with us. But all of these young people want to go to medical school. And so each of them has a separate research project. And so we're trying to increase the energy and enthusiasm for doing research, because without it, we don't find any new treatments and we'll never find a cure. This is our scleroderma program. You can see we have a ton of different doctors who help me manage all the different manifestations of this complex disease. Ian Odell was the dermatologist who did the intralesional sodium thiosulfate injections, and Amir Masood was the one who told me about the Candibactin. Well, a patient brought it to my attention, but then I went and asked him, and he was the one who shared with me the publication by Dr. Shadid. So, and who else? All of these doctors I work with routinely, but those were the 2 that deserve a special call out. And with that, I'd like to thank the Tri-State chapter that nominated the Yale Scleroderma program, or denoted us as a center of excellence. So that's really helped us increase the awareness in the community that we exist. And it helps us attract more patients to our centers and thereby increase enrollment into clinical trials. And with that, I'll take any questions. Thank you so much.